Hi, and welcome to this tutorial. It's the CMH Family Medicine Top Tips and Tutorials. I'm Dr. Madeleine Muller. Today, we're going to have a look at severe hypertension and how we manage patients with extremely high blood pressures. So what do I mean by severe hypertension? So according to our classification, these are patients who have a diastolic blood pressure of more than 110 or a systolic blood pressure more than 180. And the most important thing is to first identify your three possible groups under severe hypertension. So is this an asymptomatic patient, or has this patient come in with some specific symptoms, although there's no actual target organ damage happening, so that's hypertensive urgency, or is this patient actually having a life-threatening condition in conjunction with their high blood pressure, which we call hypertensive emergency. And we're quickly going to run through these three scenarios. So the first one is our asymptomatic patient. So this is the patient who arrived at the front, maybe for something else, maybe don't even have a previous history of hypertension. The nurses have taken the blood pressure, and now they come in and there's a little red circle around that blood pressure saying that it's very, very high. So these patients have got no symptoms, and you do have to investigate and examine them properly to make sure there are no actual target organ damage happening at the time. And quite often there's a temptation to try and bring that blood pressure down within the next few hours. So we quite often see in the clinics, the nurses might already have given the patient that 10 milligrams of amlodipine. Just remember, your hypertensives are going to take a while to work, so that amlodipine is going to take 4 to 6 hours to have any effect at all, and most of its effect will happen over a few days. So you don't want to keep that poor patient in your clinic and watching that blood pressure, trying to see it comes down. So what do we do? So if you've got a patient who comes in, the blood pressure is very high, we do want to make sure that the actual blood pressure is at those levels. So remember, if your patient's in pain, or if your patient's very distressed, or maybe they've been really rushed and frustrated to get to the clinic, that might all have an impact. So you want your patient to rest nicely somewhere without needing to have given the amlodipine. And then after an hour, you want to use that, remember, your very good blood pressure taking techniques to check what the actual blood pressure is. If you then diagnose the patient as having asymptomatic severe hypertension and they're a new patient, then you're going to start that patient on antihypertensive drugs today. And it might even be that the patient's been walking with this blood pressure for quite some time. So what would we give? So normally, if the patient doesn't have any other risk factors or issues that you will affect your choice of antihypertension, you would give your normal hydrochlorothiazide 12.5 milligrams, and you will already add amlodipine at 10 milligrams at full dose in a patient like that. If it's an existing patient, so it's a patient known with hypertension, then the first thing you want to check is, did they actually take their treatment this morning? Try and see if there's any other factors that might be playing in. And then you're going to look at their current. If they have been taking their treatment, you want to very aggressively adjust the dosing of the antihypertensives that they are on. And very important, we want to follow up these patients quite quickly. So within a week, we want to make sure that we are on track with their treatment and getting them towards target. Our second scenario is our hypertensive urgency. So these patients are now presenting with symptoms, either severe headache, shortness of breath, edema. So all of these patients, when you examine or investigate them, you're not, for example, finding that the patient's in acute heart failure, or that the patient's, for example, got other signs or possibilities of something like a pulmonary embolism. So these are literally just symptomatic, but no life-threatening complications. So the EML will tell us that these patients need to be admitted. I think we all know that there is a strain on beds. I think physicians will find it difficult to necessarily admit all of these patients, but do discuss with your local physician and at least make sure you've talked the case through with him before you just send that patient home. So these patients will treat similarly to our asymptomatic severe hypertension. We're going to treat them with 2 antihypertensive drugs, also at full dosing. But you would actually already give those dosings while the patient is sitting with you, and you might treat some of those other symptoms as well to help make the patient comfortable. The patient's then able to actually, only under the physician's permission, might be able to go home, but you're going to be reviewing that patient very quickly. So they're going to have to come in within 2 or 3 days to be able to check that you've actually managed that blood pressure. Drugs of choice, again, actually here you might combine amlodipine, and just note to not use the enalapril if the patient has a low sodium. But depending on the symptoms, you can decide which choice of antihypertensive you want to go with, and I would get the advice from the physician on this, especially if you're going to send this patient home. Our third is our hypertensive emergencies. So these are the patients where you will now find there's actually acute or ongoing organ damage. So the patient might be in an AKI and having an acute kidney injury. They might actually have a stroke, might be having a heart attack. You might see some severe damage happening within the retina, and that's actually disturbing their vision. They might have peripheral vascular disease. And all of these patients, they have to be admitted to a high care ICU setting. And we want to get them onto IV ilobutalol, which we want to monitor very closely, and we want to slowly make sure we get that blood pressure down. Very important that it's not, depending on the scenario, the physicians will decide on how quickly they want to bring that blood pressure down. So in a stroke patient, for example, there might not be such an emphasis on getting that blood pressure down quickly unless that blood pressure is extremely high. And then if you do reduce, for example, in a stroke patient, you don't want to do it more than 15 to 20% in that first 24 hours, which is one of the reasons why we want to do it in a high care setting.